Now we're going to see the hairy cell leukemia or tricoleukemia. This is a leukemia of mature B lymphocytes. The characteristic cell is a cell with finger-like projections, so it looks like fuzzy. So for that, this is called hairy cell leukemia or tricoleukemia. Now this presents in a elderly middle-aged patient, let's say middle-aged, usually men, and there would be massive hepatosplenomegaly. This is due to, because we have a leukemia that is not acute, it is a chronic leukemia, we have less than 20% blast, we could have no blast, but we have certainly less than 20% blast in the blood smear. Actually, we have no blast. Now, the white blood cell count is increased. White blood cell count is increased. And there is a massive increase in white blood cell, and because of the white blood cells that are in the bone marrow, and there is also reticulin fibers that lead to bone marrow fibrosis, then we have extramedullary hematopoiesis, and so the patient has hepatosplenomegaly. If we do a bone marrow biopsy, we will see a dry tap. We could not see anything because of the bone marrow fibrosis. The clues that would lead us to suspect this is a patient with fatigue, bleeding, infection, bleeding because there is no platelet due to the decrease in bone marrow production, infections because there are no B lymphocytes. So the patient has pancytopenia and present with bleeding, infection, massive hepatosplenomegaly. Then when we suspect this, the best next step is to do complete blood cell count and blood smear. In the blood smear, we will see these fuzzy cells with hairy projections. And the most accurate test, that is like the confirmation for the diagnosis, will be looking for tartrate-resistant acidic phosphatase and the flow cytometry that will reveal a CD11C or CD25. With this, we have the diagnosis of hairy cell leukemia, and the treatment is with cladribine. The patients respond excellent to cladribine. Some alternatives would be pentostatin. If the patient is resistant to cladribine, then we can give rituximab or another monoclonal antibody. The mechanism of action of cladribine is that it inhibits the DNA polymerase, also promotes DNA breaks, and inhibits adenosine deaminase enzyme. Adenosine deaminates adenosine, but if we have a lot of adenosine, this is toxic to the cell, and so 1, the cell cannot replicate because inhibition of DNA polymerase. 2, the cell is dying because broken DNA. And 3, we are destroying the cell because adenosine is toxic. Adverse effects of cladribine will include bone marrow suppression and neurological and renal disturbance. But the patients respond excellent to cladribine, so this is the treatment of choice. Some patients with only one dose of this chemotherapy will have remission for at least 10 years. But if the patient is never treated, can have at the end pancytopenia and massive hepatosplenomegaly. So hairy cell leukemia is a chronic lymphoblastic leukemia of B cells with massive hepatosplenomegaly secondary to bone marrow fibrosis due to reticulin fibers and increasing white blood cell counts in the bone marrow, so there is no production of cells, so we have extramedullary hematopoiesis, massive hepatosplenomegaly. Something that is characteristic is we would not see no lymphadenopathy. And the infections, bleeding, etc. The best next step is the blood smear with complete blood cell count, and the most accurate test is flow cytometry, saying CD25 or CD11C, or the tartrate-resistant acidic phosphatase. and the treatment is cladribine that inhibits adenosine deaminase, DNA polymerase, promotes DNA breaks, and alternative pentostatin. If this patient is resistant to cladribine, we give rituximab or other monoclonal antibody, or sometimes interferon alpha.